I want to do a disclaimer because this lecture is being recorded, and so the presentation is for educational purposes only and should not be used as a basis for assessment, diagnosis, or treatment of a health problem, medical condition, or disease. Those seeking personal medical advice should consult with a licensed physician or other qualified healthcare provider. All images and content in this presentation are appropriately cited and exclusively utilized for teaching, educational purposes in accordance with fair use or otherwise licensed to the author, and no contents of this presentation may be reproduced without written permission of the author. So we've got a Prospero registration, and I think those that are working on the project, this is a systematic review and meta-analysis of the impact of recombinant growth hormone on the quality of life for adult growth hormone deficiency. So what are we talking about here? So there's really three concepts that we need to look at today to give you more familiarity with the review we're going to be doing, but also just with the topic of growth hormone deficiency. So the first is what is adult growth hormone deficiency? What causes adult growth hormone deficiency? I'm not going to get into the diagnosis today. I may mention it during discussion or Q&A for those that are interested in how do you diagnose growth hormone deficiency, because it's not so straightforward. But I didn't want to focus on that today. I wanted to focus more just on understanding how one acquires growth hormone deficiency, what the treatment is, and then what are some of the outcomes associated with treatment. So the treatment for growth hormone deficiency, once it's been appropriately diagnosed, and the diagnosis generally occurs in specialized endocrinology centers, and you have to do something called provocative or dynamic testing, where we inject a pharmaceutical agent that then stimulates the pituitary to secrete growth hormone, and then we capture that growth hormone across repeat blood draws. And so it's generally going to happen in specialized endocrinology practices rather than, say, in a primary care setting. So there's oftentimes a referral from primary care to endocrinology if one suspects growth hormone deficiency. The treatment for growth hormone deficiency is recombinant growth hormone. That's different than endogenous, where we produce it from our own pituitary gland, essentially. And so we think about human growth hormone being the endogenous form that we produce, and we talk about recombinant growth hormone being the synthetic form that's then used as a form of replacement for individuals who are not making enough growth hormone. And then we want to know what's the effect of the growth hormone treatment in those who have confirmed deficiency on the quality of life. So we're really just going to focus on those three things. What's adult growth hormone deficiency? What is recombinant growth hormone? We'll do a brief section on that, not too much, just in you biochemists and so forth and biomedical individuals will be very interested in that perhaps. And then we'll talk a little bit about quality of life measures as well. So a brief overview of the endocrine system for those that are going through basic physiology and anatomy. You can see an overview of the endocrine system. This is a very rudimentary form of the endocrine system. There are other tissues that produce endocrine hormones. For example, the liver is not in here, and it produces an important hormone called insulin-like growth factor that's also under the control of growth hormone. But as a basic overview, we're going to be focusing on the pituitary gland and the hypothalamus. When we're talking about growth hormone, its production, regulation, and secretion. So endocrinology, what is it? It's a branch of medicine that deals with diseases of the endocrine system, which we just looked at. And then within endocrinology, we have neuroendocrinology. And neuroendocrinology in the classical sense refers to a subspecialty of endocrinology that deals with diseases of the pituitary gland and the hypothalamus, which is above the pituitary gland, and then the surrounding region. Surrounding region meaning if there's invasive tumors or other pathologies of that area that can affect the pituitary gland and the hypothalamus, then neuroendocrinology is very interested in that region of the brain. And so you can see here anatomically, and I like the picture on the left, because it's lit up here, and that shows the what we call the hypothalamic pituitary axis. And so you see the pituitary at the bottom looks like a little chickpea. It's about the size of a chickpea. If you've ever had hummus, that when you mash the chickpeas, it's about that size. Depends on the age, and females have a little bit bigger pituitary than males. The pituitary increases in size during pregnancy, but it's about that size, so like a tip of a pinky. And then you've got a stalk that connects it to the hypothalamus, and the hypothalamus has stimulating hormones that then influence the pituitary to produce and or secrete different hormones. So that's the basic structure of the pituitary gland. I like to anchor things with images I love neuroanatomy, so I want to show you a little bit more, just so that you're familiar with the surrounding anatomy. And so again, the green section here is the hypothalamus that sits above the pituitary gland. The pituitary gland sits inside of a hard, bony structure called the sella turcica, which simply means Turkish saddle. And you can see that it looks a little bit like a saddle. And that's part of the sphenoid bone inside of the skull base. And that bony structure is particularly important for trauma, because it's a hard bony structure. And so when people get in motor vehicle collisions or have whiplash or other types of brain injury, then the pituitary can get damaged, as it's limited by its movement, and the stalk can get stretched. And we'll talk about that in the context of brain trauma. So this is a cadaver, and you can kind of see this from different angles. And so I thought I could use my arrow, but I'm not able to use my arrow. But you can't really do that. But if you can see the hollow space there above it in the pituitary stalk, I'm not sure if yeah, I thought I would be able to use a pointer, but I can't. So hopefully that's clear. We'll go back there. You can see here the little bright spot is this. Oh, there, I'm able to use my arrow. Can you see my arrow, everyone? Perfect. Okay. So this is the sphenoid sinus. This is one of our major paranasal sinuses. And you can see that the pituitary gland sits right next to that sphenoid sinus. And there's a little, very small amount of bone here. This is the pituitary stalk, and this is the hypothalamus above it. So it's a very delicate structure. It's very rare, but you can get infections of the paranasal or sphenoid sinus that will migrate through the venous system of the sphenoid bone and actually infect the pituitary and surrounding region. And that can actually lead to a bacterial abscess or fungal. But very, very uncommon, but it can happen, which is why sinus infections need to be treated appropriately, so that it doesn't migrate into the pituitary region. But that's quite rare. This is interesting. This is what happens to the pituitary gland in pregnancy. So you can see how it's much larger. So what happens for females is estrogen surges during pregnancy, and it causes the prolactin secreting cells called lactotrophs to double or triple in size. And the pituitary gland becomes much, much larger. And because of that, it loses blood flow. And so the blood flow is restricted. And there's a condition called postpartum pituitary necrosis, or Sheehan syndrome, where when a female bleeds during pregnancy and loses a lot of blood, and she goes into hypovolemic shock, then there's a deprived blood flow and oxygen to the pituitary gland, and then that causes cell death in the pituitary gland, and that's one of the causes of hypopituitarism, and also a variant of hypopituitarism, which is growth hormone deficiency. So when you're reviewing, for the reviewers, when you're looking at etiology or causes of growth hormone deficiency, and I know one of our sub questions is, what do we expect in terms of quality of life in brain injury versus non-brain injury? We added that in there because we're very interested in brain injury, but brain injury is also a very common cause of growth hormone deficiency. But you'll probably see Sheehan's mentioned, so be aware of that. Well, this is the setup for Sheehan's. So the pituitary is susceptible to that postpartum necrosis. So this is the blood flow around the pituitary, and you don't need to memorize all of this, but those that enjoy neuroanatomy and micro anatomical things here, you don't see this on an MRI, the vascular structure. These are very, very, very small vessels around the pituitary. It's likened to like if you were to take red and blue thread and dip them in water and put them around a chickpea. That's how tiny these vessels are. And so imagine if you have a brain injury, your head gets shaken around, or you get some kind of increase in intracranial pressure, and it puts pressure into that area. Then you can actually lose blood flow. And so one of the hypotheses about how we develop pituitary dysfunction, including growth hormone deficiency, is disruption of blood flow and associated oxygen because of these vessels. Whether those vessels are damaged due to external forces like traumatic brain injury, or whether they're damaged due to internal forces such as brain edema, increased intracranial pressure, that type of thing. Pressures in Sheehan's, for example, when the pituitary is already expanded and now it's pressing up against the bone, and it can't get the blood. So just that's a little bit of microanatomy of the pituitary. There's lots of different hormones that are produced by the hypothalamus and the pituitary. I'm not going to go over all of these today, but just to be aware of this as you're reviewing the papers, we can have isolated growth hormone deficiency, or we can have other deficiencies as well. And when we have all of the hormone deficiencies, we call it panhypopituitarism, meaning we've lost function of all the pituitary hormones. And sometimes panhypopituitarism is used to just describe when you have all of the anterior pituitary hormone deficiencies. And in other settings, it also includes the posterior pituitary. So you can see here that the pituitary is divided into two sections. On the top, you have the posterior pituitary, and where we secrete ADH, which is antidiuretic hormone, which then goes to the kidneys and helps us to retain adequate water. You can lose control of antidiuretic hormone and deplete it, and then that leads to a condition called central diabetes insipidus, which is a posterior pituitary hormone deficiency. And then oxytocin is also secreted. Oxytocin is produced in the hypothalamus and then carried down these little nerve tracts into the posterior pituitary. And oxytocin is very, very important for triggering uterine contractions during childbirth. But there's a whole field of studying oxytocin in sort of biopsychology as well, and looking at the effects of intranasal oxytocin. I don't know if anyone's seen that research or not, but that is outside of traditional endocrinology and neuroendocrinology. But it's been looked at in generalized anxiety disorder, in autism. In fact, UW had a study that they were doing with autism and oxytocin. But we don't have a good way to measure that, so we don't really know how to blood levels of oxytocin don't always correlate with pituitary levels of oxytocin. So it's been hard necessarily to define an oxytocin deficiency. But in the setting of proven diabetes insipidus, we have to assume that the posterior pituitary has been damaged, and a person may not be producing oxytocin. But oxytocin is not sort of part of the traditional replacement therapy for hypopituitarism within conventional endocrinology, but it's definitely under investigation and has been for a number of years. And generally, the posterior pituitary has better blood flow. And so it tends, the hormones, after there's an insult to the pituitary, the hormones tend to be better preserved than the anterior hormones. And the anterior pituitary hormones are luteinizing hormone, follicle stimulating hormone, thyrotropin stimulating hormone, and then prolactin, growth hormone, and adrenocorticotropin hormone. And then you have your releasing hormones that are produced in the hypothalamus. So GnRH is gonadotropin releasing hormone, TRH, thyrotropin releasing hormone, PRH is promoters of prolactin, and then the one that we're interested in is growth hormone releasing hormone, and then the final one is CRH, corticotropin releasing hormone. So the GHRH is interesting because the hypothalamus can be damaged without the pituitary being damaged, or the pituitary can be damaged without the hypothalamus being damaged. So really anywhere along this axis of where you see GHRH and GH, anywhere along that continuum of that axis can lead to growth hormone deficiency. So, and we don't necessarily need to know, and we don't normally differentiate in clinical practice and try to say, is it the hypothalamus or is it the pituitary that is actually damaged? We just accept that the downstream hormone, growth hormone, is not being secreted adequately, and there needs to be replacement. So, growth hormone deficiency. So these are the variants of hypopituitarism. Sometimes you'll see when there's a deficiency of testosterone, pituitary based, or estradiol, and it also includes progesterone by extension in females, then you're going to see sometimes you'll see some papers called it luteinizing hormone or FSH, follicle stimulating hormone deficiency. The sort of the academic name is hypogonadotropic hypogonadism. And the gonadotrophs are luteinizing hormone and follicle stimulating hormone. So that's where that terminology comes from. So you want to be familiar with that name, with both of those. And that's the deficiency that they're talking there. They're talking about inadequate secretion of luteinizing hormone and follicle stimulating hormone, which then leads to a testosterone deficiency in men and biological male, and estradiol deficiency in biological females. And then, of course, the progesterone is under control of that as well, under the estradiol by extension through the corpus luteum. And so you'll end up developing both estradiol, which is the main form of estrogen during the years of menstruation, and then as well as progesterone deficiency. And then you'll also see central adrenal insufficiency, sometimes referred to as adrenocorticotropic hormone or ACTH deficiency. Sometimes that's referred to as hypocortisolism as well. And sometimes it's referred to as secondary adrenal insufficiency. And secondary, central is sort of more academically correct because central implies that the problem is coming from the hypothalamus or the pituitary. And so you'll see older literature talk about tertiary adrenal insufficiency, and they're talking about insufficient corticotropic releasing hormone from the hypothalamus. And then when they're talking about pituitary, they'll say secondary. So secondary applies to the pituitary and tertiary applies to the hypothalamus, but collectively central. And since actually we don't have a good way to figure out whether it's the hypothalamus or the pituitary clinically without, in the research setting you can do it, but it doesn't make sense because it doesn't change treatment. We just call it collectively central adrenal insufficiency. And I want to be clear about central adrenal insufficiency. This is not adrenal fatigue syndrome. And so that's a concept that's used in alternative medicine with tenuous evidence. But this is a recognized condition within clinical endocrinology, and it's a life-threatening condition. And so it's really it's about the base level of cortisol, but it's also about the ability to mount a stress response in response to a surgery, an illness, a very stressful life event. And if there's inadequate cortisol response to a stressor because the axis is not working, then you can die from that. And it's called an adrenal crisis. And generally, you can go into shock from that. The blood pressure drops, the blood sugar drops, and so on, and you can die from it. And so, this is the life-threatening condition within hypopituitarism that we need to be aware of, just for your background. And that's when you identify that particular patient is under close surveillance. They actually have a medical bracelet or a chain that they wear, so that if they were in an accident, they're unconscious, the paramedics actually know, or surgeons know. And then when they're in the hospital and they're undergoing surgery or any other intervention, you actually have to give them a large dose of intramuscular or intravenous synthetic. You have to give them glucocorticoids, corticosteroid. Solucortef is the one that's generally used. Central hypothyroidism is it presents exactly like primary hypothyroidism. And when we think about hypothyroidism, we're talking about 99% of cases are going to come or more are going to come from the thyroid gland. The thyroid is dysfunctional for various reasons. The most common is Hashimoto's thyroiditis, which is an autoimmune condition. That's roughly 97, 99% of cases are going to be primary hypothyroidism are going to be autoimmune. That's not what we're talking about. The gland is working fine. It's that the signaling hormones from the hypothalamus or pituitary are insufficient, and therefore they're not stimulating the thyroid. So in this case, for those that are in clinical medicine, in this case, you're going to have a low free thyroxine or free T4, and then the thyroid stimulating hormone should go up if it's primary, and it doesn't. It either stays normal or it's low. This is very, very rare, but it does happen. It's oftentimes euthyroid 6 syndrome or non-thyroidal illness. And so in my facility, we track them for 3 to 6 months because you often see it's not actually central hypothyroidism. It's actually euthyroid 6 syndrome. So I've seen people that look like they have this at 1 month, and I mean 0 times 0, 3 months, and then at 6 months they're normal again. So this is often prematurely treated, and then people end up on unnecessary thyroid replacement. So it's more of a surveillance thing. Central diabetes insipidus, again, antidiuretic hormone is produced in the posterior pituitary, and that basically goes to the distal tubules of the kidney, helps us to retain water. And so when we lose that, we have diuresis, which is simply we're peeing out water, and we get, it looks like diabetes mellitus, but it's not. So which is an insulin resistance syndrome or a pancreatic disorder. So completely different disorder. And there's been a movement to get rid of this name because it confuses people. And so the hormone, antidiuretic hormone, is also called arginine vasopressin. And so there's been position papers that have suggested that we call it AVP deficiency instead of central diabetes insipidus. But it presents similar to diabetes. It has the polyuria, which is frequent urination, and including nighttime urination, as well as excessive thirst, although there is an adipsic form where they have no thirst, which is odd, which has worse outcomes because they don't drink enough. And the opposite of this is syndrome of inappropriate antidiuretic hormone. And this is where there's too much of the hormone. And then there's actually water retention and other issues like hyponatremia, which can also be life-threatening, or low sodium in the blood. This is very, very rare, and it usually happens in the early setting in acute trauma or immediately after surgeries. And it's basically when the pituitary is damaged and it just dumps out all of this hormone into the blood circulation, and you get this surge. And then it can flip then later and turn in, as the hormone gets depleted, it can flip to central diabetes insipidus later on. And then finally, we have prolactin abnormalities. And we usually see these, the classical is a prolactinoma, which is a tumor that secretes prolactin. But we can also have prolactin deficiency as well when there's been damage to the pituitary gland. And the clinical significance of that we don't really know, other than, for females who cannot lactate as a result if there's deficiency. So that gives you an overview as you're reviewing of the other deficiencies that are part of the complex of hypopituitarism. And so as reviewers, you're going to be looking to see, is it isolated growth hormone deficiency, or do they have any of these other deficiencies? And what would you imagine? And that's because that's one of the questions we're going to look at, which is, if you've got isolated growth hormone deficiency and you replace the hormone versus you have many hormone deficiencies, who do you think is going to have a better quality? Who do you think is going to respond and have a better quality of life? Right. That's our hypothesis. And the literature tends to show that, because replacing these hormones and getting it right is very difficult. It's very advanced medicine, and because each hormone influences other hormones, and the hormones are constantly changing and dynamic. And so if you've got panhypopituitarism and now you've got to replace estrogen, right? Estradiol, progesterone, cortisol, desmopressin for central diabetes insipidus, And then you add in growth hormones, get very, very complex pharmaceutical management of hormones. And now you've got to figure out all of these things. And now somebody goes through a stressor, and you've got a stress dose. And so you got to change your hydrocortisone dose and so forth. And it's just a moving, so it's very, very difficult managing panhypopituitarism or polyhormonal deficiencies. Clinically, very, very difficult. A lot of changes constantly, and that patient needs to be tracked very, very closely for life. So our hypothesis is consistent with prior literature that the quality of life is likely going to be better. They're going to respond better to growth hormone if they have isolated growth hormone deficiency, because it's just a straight shot, right? It's just a single treatment, single outcome versus many treatments and one outcome. Okay. So this is something to learn here is the growth hormone IGF-1 axis, and you're probably coming across this. Growth hormone, IGF-1 is a peptide hormone. So growth hormone is a peptide. It's 191 amino acids for our biochemists. IGF-1 is a smaller peptide. It's 70 amino acids, but growth hormone is the main stimulator of IGF-1. And both growth hormone and IGF-1 have receptors peripherally in almost all of these tissues, but those receptors are different. And so really, when we think about growth hormone, we talk about the growth hormone IGF-1 axis because they work as brother and sister. They work together. But when you lose growth hormone, the IGF-1 goes down. And so clinically, we use IGF-1 as a screening test for growth hormone deficiency. So if the IGF-1 has gone down or is low, and there's a known cause of growth hormone deficiency, such as head trauma or postpartum hemorrhage, or we found a tumor on imaging, for example. And then we have a low IGF-1, which is not what you would think. It's actually below the mean, are the clinical practice guidelines. So it's not actually a low IGF-1 below the lower limit of the reference range. It's actually within the normal range. And there's different algorithms in medical decision-making trees for when you actually run diagnostic testing. But this is the growth hormone axis. And so collectively, growth hormone and IGF-1 have a tremendous role in human health. And a lot of times we think about growth hormone deficiency in childhood. Like maybe some of you had friends growing up that weren't growing in school. Like everybody else, they were much smaller. I remember 2 in my school, and I remember their names actually. And they were like the smallest guys in the class, and then suddenly they were bigger than everybody. And there was one guy that was kicking everybody's butt after that. He became a wrestler, and he was like super strong. And before that, he wasn't. And so he was getting growth hormone injections because he had childhood growth hormone deficiency. Think about developmental milestones. And if they're not meeting those developmental milestones and they're not growing, then you suspect growth hormone deficiency. That's not what we're talking about here. We will have some patients that are transition patients that had childhood growth hormone deficiency, and then they carried that into adulthood. Some resolve, and then it moves into the adult setting. But the other population is acquired in adulthood. So adult onset acquired growth hormone deficiency, which is a very different population than childhood onset that transitions into adults. And so developmentally, especially neurologically, the brain doesn't fully develop until 25 in biological females and 28 in males, roughly. And it depends on the paper, but males don't finish the myelination process of the brain on the outer limit until 28. So the human brain's not fully developed. It's much later than 18, actually. And biological males tend to develop more slowly, and that kind of fits into the stereotype that women may be more mature and make better decisions earlier than men. There's actually a neurological basis for that. But the other reason is they're exposed early, right? They're exposed to growth hormone in childhood and in adolescence during those developmental years. So they're getting that therapy throughout childhood or adolescence, and then they continue that into adulthood. So it's a very different exposure, and they would have been exposed for many years, right? So they could have been exposed for 5 years, 10 years, and then they're carrying that in. Whereas somebody that has adult growth hormone deficiency that's acquired, they've had a reason for that. They've had a tumor or a brain injury or other types of infections, and then they go on growth hormone. So we'll talk about our hypothesis on who would respond better in terms of quality of life? Would it be the childhood onset carried into adulthood, or would it be adults with true acquired growth hormone deficiency? So we'll look at that, and we can share ideas a little bit later on. But you can see here all of the tissues that it affects. And the one that's most interesting to me is the brain, because that I do brain injury research, and so I'm always fascinated by the effects of growth hormone and IGF-1 on the brain. But it's very, very important for the bones. And so if you don't have enough growth hormone, you can develop osteoporosis or loss of bone mineral density. And we see this compounded in postmenopausal females. So let's say, for example, they're postmenopausal, they're not on estrogen replacement, then they get a brain injury, they develop growth hormone deficiency. There's a delayed diagnosis, which there often is, 5, sometimes up to 15 years. I found a guy at 33 that had an injury at 16. That would be 17 years, who had not been diagnosed, and he had severe osteoporosis of the spine, even though he's a big guy and worked out. So you can have osteoporosis, loss of bone mineral density, and it can be compounded in females as they lose natural estrogen if it's not replaced. The other one, muscle growth and development. So it works very much like testosterone for maintaining muscle growth, repair, development, and you can get muscle atrophy in severe cases, but just loss of lean body mass and increased fat mass with growth hormone. And then there's a whole slew of cardiovascular effects as well. In childhood on cardiovascular development, in adulthood on maintaining proper function, especially the left ventricle of the myocardium, or the left ventricle is supported by growth hormone and IGF-1, and you can get left ventricular atrophy, not atrophy, but hypertrophy, which is a reduced, it's a type of reduction in the size and function of the left ventricular, and you get left ventricular dysfunction secondary to growth hormone deficiency. There's increased risk of mortality in untreated growth hormone deficiency in both males and biological females as well. And then you can see the neuronal development as well as preservation of brain function as well in adulthood. And we often see cognitive problems in the context of growth hormone deficiency. So you're going to see things, when you look through quality of life questionnaires, you're going to see a lot of psychiatry and psychology in there. You're going to see people that have memory problems, that can't think like they used to think, that are not able to plan, mood disorders, that type of thing. And they get better with growth hormone replacement often. It improves those symptoms. And there's other areas as well, but I'm focusing on the bone, the muscles, the cardiovascular system, and the brain. There's also adverse lipid profiles. So it can be a cause of dyslipidemia, meaning various types of changes in lipids, whether it be LDL, HDL, total cholesterol, small particle LDL as well. Various changes on lipids. And so improvement in lipids, cholesterol with growth hormone treatment, improvement in cardiovascular function, improvement in lean muscle mass, improvement in bone mineral density, and in some studies, improvement in mood, cognition, fatigue, energy, that type of thing. So we'll go over some of that. This is just a chart that I had compiled in my dissertation work around all the different effects of growth hormone and IGF-1 in the brain. And so you can see that there's many different brain regions that have growth hormone receptors, as well as IGF-1 receptors. And you'll see memory centers like the hippocampus. When we think about the hippocampus and perihippocampal region, we think about Alzheimer's disease. But as you have growth hormone deficiency, you lose stimulation of that important memory center, which helps you to encode and retrieve memory. And so you can get memory deficits as well. And then we have all sorts of neuroprotective effects. And so growth hormone promotes neurogenesis, which inside the hippocampus, there's a small region in the hippocampus that actually creates stem cells called the dentate gyrus of the hippocampus. And growth hormone helps to stimulate neurogenesis in that particular area, along with exercise being a big one as well. So some of the neurological effects, there's people that do research just in this area on the effects of growth hormone and IGF-1 on the brain. And another interesting one is you can see protection of the hippocampus in beta amyloid induced toxicity. So we see in brain injury, people can, as a result of the damage, we get beta amyloid plaquing. And so we're actually, and of course, beta amyloid toxicity is diffuse in Alzheimer's, but it tends to target the hippocampus in particular. So we don't know yet if people who have growth hormone deficiency are at increased risk of Alzheimer's disease definitively, but at least the mechanism suggests that might be the case. So here's some causes of growth hormone deficiency. And you can see there's many different causes. You can see on the right-hand column that there are a number of genetic disorders, and you'll see those as causes of childhood onset growth hormone deficiency. You'll also see on the left column acquired, which means it could be acquired in childhood or teenage years, but particularly this is a table for causes of adult growth hormone deficiency. So these are various causes. The vast majority of these at the top are going to be tumors and what we call cellular masses, with pituitary adenoma being one of the most common causes. So the ones that are underlined are considered to be more common causes of adult growth hormone deficiency. And of course, you see traumatic brain injury, sports-related head trauma, and blast injury as common causes. And there's been a big interest in the last 20 years, including a lot of the work from some of my mentors at UTMB and Kevin Yuen here, who was my primary mentor in really documenting the effects of traumatic brain injury in causing growth hormone deficiency. And so that can happen through different types of brain injuries. Blast injury has been researched heavily in the last 10 to 15 years in the military. And this is due to a pressure wave that basically goes through the skull and causes shearing forces inside of the brain. And this happens, unfortunately, inside of combat scenarios. And so a lot of our military can have blast injury. And we're interested in this, right? We're looking at military versus non-military, and we have a hypothesis about that. So I'll come back to that, and we can talk about that. But or we can talk about it now as well. But we'll at least have a little session on that at the end. And then surgery, right? Once you have a tumor, sometimes you have to have surgery, many times. And that surgery itself, it's a very delicate area, and you can damage the pituitary, the hypothalamus in the course of surgery. Also cranial irradiation or pituitary radiotherapy. And so those are going to all be common causes. So already highlighted traumatic brain injury, which we're looking at in our subgroup analysis. This is an example of a motor vehicle collision mechanics, coup contra coup injury. This is a large part of my population that I work with have had concussions or worse brain injuries inside of the setting of motor vehicle collisions. And this is a whiplash type injury, which you can see here that the stalk of the pituitary is being stretched, and you can see the vascular system and little arterioles and venules around the pituitary being stretched and potentially damaged in the context of a whiplash injury. So this is probably, for most of you, going to be what you see in your careers, unless you're working in a specialty center like Barrow Neurological Institute, where my mentor works, which is really a tumor and neurosurgical center. And so the vast majority of their cases are tumors. But for those of us that are not in those specialty centers, in an oncology type setting, this is going to be one of the main causes of growth hormone deficiency, is going to be brain injuries, concussions, and particularly coup contra coup injuries, where you get a whiplash and the brain is just sloshing around inside of the head, and it can lead to damage. And I'll talk about, this is an area of ongoing research for our team, and I'll tell you, we're about to publish this year, and I'll tell you what we found from some of our research on predominantly motor vehicle collisions, but just simple concussions leading to growth hormone deficiency. So this was written by Kevin Yuen and team. You'll notice that some of these authors are also on our paper. Kevin Yuen is my primary mentor. Brent Mazel and Tamara Wexler and Randall Urban are all going to be on our paper, as well as kind of senior authors and content experts. So this was a recent paper that they published on recognizing growth hormone deficiency in mild traumatic brain injury or concussion. and then how do we optimize those patients. And so what they're recommending here is, what they're saying here, which is consistent with the literature, is that anybody who's had a mild TB or concussion can develop traumatic, traumatic, post-traumatic growth hormone deficiency. This is a poster presentation we're going to be presenting most likely at Endocrine Society next summer, and then a paper as well on this. And this is data from University of Texas Medical Branch, also from my center, and then from Tamara Wexler's center, Neuroendocrine Associates. And what we found is this is a selected population of individuals that have chronic post-concussion symptoms at greater than 12 months after a concussion. So that's what we're looking at. We're asking the question, if you haven't resolved, if the concussion symptoms haven't resolved, and we usually frame that as what we call persistent post-concussion symptoms, or sometimes called post-concussion syndrome, and you present to an endocrine center and it's been at least 12 months, what's the prevalence of growth hormone deficiency? And we found that it ranges somewhere between 18 to 22%, or 1 in 5, which is very, very high, right? And so when you're thinking about individuals that have had a concussion and haven't gotten better, that's automatically a referral to endocrinology. And I'll do a different lecture on why all endocrinology is not created equal, and why even if you refer to general endocrinology, they often miss it. It's not uncommon for them not to actually test. I've seen that happen at well-reputed university medical centers, where they didn't diagnose it, and then they come to our center, which is highly specialized in this area, and we do diagnose it. You can see that there's many sequelae, symptoms, conditions that evolve if you don't treat growth hormone deficiency. So you want to catch it and you want to treat it. It's a very serious condition, and it's often not taken seriously enough because it's insidious and it develops very, very slowly. So it's not like you're going to have an adrenal crisis and die overnight, but you might have a fragility fracture from osteoporosis, and you might die early and have longstanding disability as a result. Or you might die early due to cardiovascular disease. Or you might not achieve your life goals and your life purpose because you didn't have the cognitive capacity, especially if you're doing intellectual work. Or if you're a physical laborer, you just don't have the strength and the stamina, right? And you can't keep up. And so that could affect the entire trajectory of your future and your family. So we have to think about these things in a human way, right? And we're very technical today, but it's good to step back and say, to look at the human story and the narrative of someone that had growth hormone deficiency and didn't have treatment. And I'll give you guys a case about that with one of my patients that I think is a good example of delayed diagnosis a little bit later today. But very serious consequences if we don't diagnose it. And because concussion is so common now and so many motor vehicle accidents, and maybe the self-driving cars will help someday lower that burden. But right now, humans are fallible and we lose attention, and there's lots and lots of motor vehicle collisions. So that's not changing anytime soon, especially with texting. We get a lot of accidents in the legal setting where somebody's texting and then they look down and then they run into somebody from behind. So don't text and drive. See, I'm going to be like that 1980s, like, don't do this, don't do that. Don't text and drive. That's my message today. Okay, so these are some examples of imaging. I'd like to kind of show you the difference. So on the right, you can see that this is a normal pituitary gland. You can see the stalk, and still my things was working and not working. And on the left, I think you can see the difference. This is a macroadenoma, a very big tumor that would require surgical resection. And then this is another tumor called a craniopharyngioma. You can see the difference between the left and the right. This is pituitary apoplexy after a postpartum hemorrhage. And so this is Sheehan's. So that's actually what happens to the pituitary region after birth, after there's been postpartum. Isn't that crazy? Yeah, it's a disaster. And so we've got, you can see diffusely how basically the pituitary increases in size, and sometimes there's peripheral hemorrhage as well, or without hemorrhage. See if there's anything else. let's see what we've got here. This is an example of empty cella. So you see how on the right, the pituitary is missing? This is where the pituitary has gotten compressed. This often happens in the setting of increased intracranial pressure. So if you suspect intracranial hypertension, this is a stigmata on neuroimaging of intracranial hypertension as the pressure increases. And so the pituitary gland gets smashed down essentially due to that increased cerebrospinal fluid. All the black stuff around that is cerebrospinal fluid that's pressing it down. That can also happen in the setting of trauma when there's been increased intracranial pressure as well. And then really the gland is a semblance of what it used to be. This is an example of transsphenoidal surgery to remove a tumor. So what they do is they go in through the sinus cavity, back through the sinuses, and then with cameras essentially, and then they remove the tumor. And obviously you can imagine that, that's not going to happen in a way where you preserve all of the cells in the pituitary gland, so the gland gets damaged. This is a different approach when you have a very large tumor. It's what's called a transcranial pituitary surgery, and you actually have to cut out part of the frontal bone, which is a craniotomy procedure, and then you lift up the brain, the orbital part of the frontal cortex, and you go under, and then the tumor's taken out that way. And again, any one of these surgeries can lead to damage. And then there's also radiotherapy to deal with tumor as well. And the radiotherapy itself can damage cells in the pituitary and cause growth hormone deficiency. We already talked a little bit about some of the signs and symptoms of growth hormone deficiency, but it's often things you wouldn't expect. Like, have you seen, as you're looking at the quality life questionnaires, have you seen things around the social arena, like social isolation? Has anybody looked at the questionnaires? We'll look at those. We'll look at the most common questionnaire today, but there's increased social isolation. In fact, one of my endocrinology mentors years ago, he treated a ton of growth hormone deficiency, and I used to refer to him for diagnostic testing before I got authorized to do it myself at my clinic. But basically, I said, well, there's all of these what we call non-specific symptom. Is it a specific symptom that leads us to know the diagnosis or the organ system or the pathophysiology involved? And so most of the symptoms of growth hormone deficiency are non-specific. So you have a loss of bone mineral density. What is it? Is it hyperparathyroidism? Is it growth hormone deficiency? Is it postmenopausal? Is it any other disorder of bone mineral metabolism? So you don't really know. And then you have fatigue with growth hormone deficiency, which could be just about anything. And then you have problems with cholesterol, which could be just about anything. And then you have psychiatric symptoms, which could be many, many things, right? And so there's nothing within growth hormone deficiency that's specific. But I did ask one of my mentors, and I said, is there anything that really tipped the hat where you knew before you tested them? And he said to me, social isolation. That was the one thing he said. He said, just in my clinical observation, and that's never been proven in any kind of study, but he had treated, hundreds, if not thousands of cases. And I just asked his clinical impression, and that's what he said to me. He said, that's the one thing that tipped me where it raised my pretest probability. It was that they were now socially isolated. So you can see here that that's part of the quality of life measures we're going to be using. We're going to be looking, so you can see increased social isolation, decreased quality of life, energy, drive, and even self-esteem and self-confidence. And I do work with a lot of growth hormone deficiency, and routinely people tell me, yeah, I don't have the self-confidence I used to have. And we went over the cardiovascular effects. Insulin resistance is another one. And we talked about changes in adipose tissue, changes in bone and skeletal muscle. This is a chart, all of you are welcome to any of these slides if you keep them for personal use. If we just and I'm not an enforcer, I'm a truster. So if we share these with you, I just ask you keep it for your personal use. And so this is just some of the stuff that I had compiled in my dissertation, which tells you all of the interesting stuff in a little bit more detailed way about what happens when you have growth hormone deficiency. So in body composition, physical performance, cardiovascular, metabolic complications. And of course, the quality of life, which is what we're talking about. We will be doing in the future other papers, and so if you've enjoyed this one and you're still in the research setting, we intend to do one on cardiovascular, and we also want to do one on neurocognitive, neuropsychiatric, probably as a sequence. And we have to talk to our other group to see which one they want to do first. But when we finish quality of life, we then will either move on to neurocognitive, neuropsychiatric, or cardiovascular, but we'll do both of those at some point. This, for the chemists in the room, is just the peptide. So you can see there's 191, right, amino acids. So actually there's 190, and then you got your hydroxyl group at the end. So that's what growth hormone looks like. That's a nice 3D model of growth hormone. And then this is showing the interventions, which is recombinant growth hormone therapy. And this is a subcutaneous injection right now that's done nightly at bedtime. And you can do it, you can draw it out of the vial, or you can do it as a pen system. We now have long-acting growth hormone as well, but there's still research going on. So normally when I prescribe, I'm doing nightly injections until we have more data on the long-acting hormone. But this is recombinant growth hormone. And recombinant, again, is made in a lab. And so this is the legality. So let's talk quickly about the legality, because that's just, I want you all to be aware of it as future practicing doctors and so forth. Some of you don't want to prescribe growth hormone unless you're probably in specialized endocrinology setting. Doctors have lost their licenses for that. And so it's not a controlled substance. It's technically a legend drug, but it's got this sort of strange legal framework that came about as part of the Crime Control Act of 1990, 101st Congress. And it was sort of lumped in with anabolic steroids. And so you can see here that there was an amendment to increase the criminal fine and imprisonment and penalties for the knowing distribution of or possession with intent to distribute human growth hormone for any use in humans other than treatment of a recognized disease or medical condition. And so that has to be, if that were taken in a legal setting, then if someone is treated with growth hormone without doing a proper provocative test, which is going to be the stimulation test, diagnostic test that's generally only done in endocrine centers, then there wouldn't be truly a confirmed diagnosis of growth hormone deficiency, and there could be serious legal implications. And so you can see down at the bottom, this is a prescriber certification, and this comes from paperwork that I have to do when I prescribe, and it says I certify that this medication is not being prescribed for anti-aging, cosmetic, or athletic performance. And there's debate over how much government should control things that we put in our bodies. We can eat as many Twinkies as we want, and that kind of thing. But this is a vital hormone that people do lose with age. But I do not, and a legitimate use is not currently considered to be just because you have age-related declines in growth hormone secretion that you can just give it for anti-aging medicine, although that's being done. And so you will see growth hormone centers around the country, sort of anti-aging medicine centers that are using it for anti-aging purposes or for doping, for athletic performance. It is a doping agent, and it can be used for cosmetic purposes in the sense that it helps improve skin collagen as well. So none of those are considered legitimate usages, and doctors that are doing it for that reason could lose their license, and technically they could go to jail. So a lot of caution needs to be to approach this with caution. And so it's got to be a recognized medical condition, and it's got to be medically necessary. And so generally within the standard of care, that's going to be that big list of things that we looked at that are known causes of growth hormone deficiency. There can also be idiopathic growth hormone deficiency, which means idiopathic means we don't know the cause, and we've ruled out everything else. But that has to be, again, confirmed with formal diagnostic testing to have a legitimately recognized condition. Okay, Perfect. So this is just another chart of benefits of growth hormone deficiency from some of the papers. This is actually mostly brain injury, actually, but these same benefits cross over with other types of other causes of growth hormone deficiency. So we've covered some of this, so I won't go over this again. But it is the psychiatric I always find interesting, and we have a couple psychology. We had psychology backgrounds, right? Raise the hand, psychology background, yeah. And wait, was anybody doing additional psychology studies here? I don't remember. Okay, no, okay. Reduced paranoid ideation, psychoticism, et cetera, et cetera. So increased self-confidence and normalization of socialization. So that most certainly plays into the quality of life that we're going to be looking at. And then you see below quality of life, they're including activities of daily living, fatigue, and social normalization. If you're really interested in sort of looking at clinical practice guidelines around this is the most contemporary guideline internationally as well as in the United States. And this is from the American Association of Clinical Endocrinologists and American College of Endocrinology. And again, you see Dr. Yuan, who's also on our paper, is the lead author and chief of the task force here. So if you want to learn everything about growth hormone deficiency, the diagnostic process, this is a great paper to reference. Okay, so I'll kind of sum things up with the work that we're doing. We're looking at overall quality of life as measured by the pooled standardized mean difference of all reported quality of life instruments. The most common instrument is called the quality of life assessment of growth hormone deficiency of the adult. And sometimes the acronym is then, that was the original acronym, and then later on they changed it in some of the papers to adult growth hormone deficiency assessment. It's the same construct, same questionnaire. So that's the most commonly used, and so you're going to see that one all over the place, and then you'll see some others as well. I wasn't going to go over all the instruments today. I just wanted to give sort of a flavor or an example of one of the instruments and look at the questions with you, because you'd be very surprised probably when you see these questions that's what we're actually looking at, and that growth hormone deficiency can actually change some of these things. So I wanted to look at this with all of you. And so as we look through some of these questions, we're thinking about different constructs, like, is it mental, psychological, is it physical? And that's actually part of the quality of life domains that we're looking at. So physical, mental, psychological, social, and immediate environment. So as we go through it, you can think, what kind of construct are we looking at? And then do these constructs overlap at all? So you can see I have to struggle to finish jobs. Why might that be? It could be memory and also executive function. And so growth hormone does have some dopaminergic or dopamine enhancing properties. And so the motivation could be there. It could be procrastination. It could be drive to follow through. It could be planning. So what we call executive functions. Or so any of the cognitive. So more broadly, probably cognitive, which includes the executive functions. And so that could be there. But it could also be fatigue. Could also be excessive daytime sleepiness, which is also one of the symptoms. So if we look at number 2, I feel strong need to sleep during the day. Well, if you need to sleep during the day and you're actually sleeping during the day, you might not finish the jobs that you're trying to do. So that both of those could be related to physical and or mental, psychological, or you could be depressed as well, or you could not exercise anymore, which helps us to be more productive. So there's lots of different things to think about. And then you start to see concepts like loneliness when you're with other people, having to reread things, which is again cognitive, difficulty making friends. Again, that's going to fall in the social sphere. A lot of effort to even do simple tasks, again, falls in very similar to finishing jobs. Difficulty controlling emotions. So the cognitive regulation is not what it used to be. Remember, growth hormone influences the frontal networks, and that gives us cognitive control. It helps us to not say things that are blurt out things that might hurt other people's feelings or might not be appropriate for other contexts, or to demonstrate that outwardly. even though we all have emotions and we feel upset, losing track of what you want to say, the lack of confidence. Why might there be a lack of confidence? What just any hypotheses on that? Could be, but it could also be self-efficacy as well. Meaning, if you're not able to perform at a previous capacity, and that's very common in the brain injury setting. People, our identity is often wrapped up. I mean, ideally, it wouldn't be, right? But ideally, we would just feel completely whole and good about ourselves, regardless of our achievements, right? That would be like an unconditional love for ourselves. But as human beings, we're not quite like that, right? We get wrapped up in what we do, and that's meaningful, and we have purpose in the world, and that's what we sort of call self-efficacy. And so, if we're not able to perform at a previous level of capacity, we lose self-esteem and we lose self-confidence. That's just part of being human. And so you're all welcome to read through this, but as you read through it, think about the mental, psychological, the social constructs, the physical constructs, and then how all of those things might kind of overlap, just to kind of humanize it. So as you always say, as researchers, we sometimes, we're researchers or scientists, you get kind of outside of the human element. So just try to go back into the human side and see what individuals who have this might be struggling with, and that can always, for me, that makes our work more meaningful. It makes you wonder, what's driving it, right? Is it where's it coming from? I mean, we know now that the brain is full of receptors for both growth hormone and IGF-1, and so is it biochemical in that sense, or are there other factors like the loss of sleep and loss of confidence? I mean, of course, there's always an underlying pathophysiology that can be there as well, but kind of fascinating, especially as you come in to see that, wait a minute, this looks like a mental behavioral health discipline. This doesn't look like endocrinology. What's going on here, right? So I find that fascinating as well. So let's go ahead and look at the final slide, which is our analysis of subgroups and subsets. And so we already talked a little bit about the first one. We're interested in the following limited set of a priori effect modifiers: adult onset versus childhood onset, which are your transition patients. And we hypothesized that it would have a lower impact in those with childhood onset versus those with adult onset, simply because they've had an exposure that they're probably habituated to. They've already had exposure to the therapy. Whereas when you have a novel exposure, oftentimes the magnitude of effects are stronger initially. Like, you'll see that with various types of pharmaceutical interventions where you start a drug and somebody has a notable initial benefit, and then it sort of habituates over time. So that's part of that hypothesis. Brain injury versus non-brain injury. When you've had a brain injury, it's not limited to pituitary dysfunction. There's many other things that could be there that are not necessarily going to benefit from growth hormone replacement. And so, exactly, perfect. And then how about military versus civilian population? What do we think? There could be repeat concussions, right? Or injuries. There could be subconcussive injuries. Do we know what subconcussive injuries are? Okay, so there's an idea within the brain injury space of what we call repetitive subconcussive insults, meaning they don't meet the threshold of a concussion diagnosis, but the cumulative effect of repeat sub-threshold insults basically damages the brain. And so we think about that in boxers in particular. So we now call it chronic traumatic encephalopathy. Have people heard of that term before in the news? Maybe. We used to call it dementia pugilistica, which a pugilist is I believe it's Latin originally, or at least derived from it, but it means a fighter, a martial artist, a warrior. And so dementia, that's a result of getting your head knocked around over and over and over. So it's all about the codification of the term chronic traumatic encephalopathy. So it's you can check it out on Netflix or on Amazon or whatever. And it's been criticized as not being 100% accurate, but you get the flavor for it, which is chronic traumatic encephalopathy is documented in professional football players. It does have far-reaching consequences, and you see that in boxers. Rugby would be another one. And we don't know enough about soccer headers yet, but we suspect enough soccer headers. So soccer is a big deal. Hockey's another one you can see it in. Um, and then obviously in the military, and especially explosive experts that are working in close with repeat blast injuries. So you could have subconcussive blast injuries, and then it just accumulates over time and it damages the brain. So that's one reason in the military population. The other is that there's oftentimes polytrauma, right? It's not limited to concussion or brain injury. There's peripheral injuries, and when there's chronic pain, and chronic pain has a very adverse effect on the brain over time. And so we know there are sites in the brain that will actually shrink or atrophy in comparison to normal controls in the chronic pain setting. So there's a host of, that's a separate lecture, but there's a host of biochemical changes in the chronic pain setting that lead to insults on the brain, including sleep loss, right? Including sleep deficits, because when you have chronic pain, oftentimes you can't sleep. And then there's the medications on top of it. And so when there's a chronic pain setting in the military and in the context of polytrauma, this also magnifies it. And then there's the psychological and moral injury, right? So there's PTSD. We've heard about post-traumatic stress disorder. We now look at post-traumatic stress disorder as a biological continuum. It's not a psychological disorder in that sense, and most of the mental disorders aren't. But we know PTSD can damage the brain over time, and particularly through dysregulation of the hypothalamic pituitary adrenal axis, and it oftentimes starts out with surges of cortisol, and then the cortisol kind of burns out. But that can actually post-traumatic stress disorder can actually damage the brain directly. So it's sort of like an internal endogenous brain injury ongoing from the post-traumatic stress. So that compounding of polytrauma, chronic pain, and PTSD within the military population makes it a very difficult population, and they tend to amplify each other as those conditions compile. And they've actually referred to, there's an entity we call the polytrauma clinical triad, which you might be aware of or not be aware of. And it's been mostly researched in the military, but also civilians. And it's when you have concussion, chronic concussion symptoms, chronic pain, and post-traumatic stress disorder. And now instead of 5 + 5 + 5, it's 5 cubed. Does that make sense? It's exponential in the effects. It's not just additive, because these mutual conditions amplify each other. So that's what we're thinking about. That's one of the reasons we hypothesize that there's going to be less of an effect in the military population. But we'll see. They're just hypotheses. We can get proven wrong, and that's a great thing when that happens as well. Biologic sex. This is an interesting. And I wouldn't expect too many answers on this, but anybody want to, and we can be totally wrong on this, but what do we think male versus female response? And it particularly pertains to estrogen. So there's two things. So the higher the estrogen, the lower the IGF-1. So estrogen tends to lower IGF-1. And so if females are on birth control, for example, and this is important, and I don't know if the studies will be looking at this or not, but if they're on birth control or on any type of estradiol replacement, what that does is it lowers the IGF-1. And so remember, we need both. Part of the effect of growth hormone treatment is the IGF-1. So when you give growth hormone, remember, we've got brother and sister hormones, right? IGF-1 is secreted from the liver. We've got all these receptors for many of the same tissue groups as growth hormone. And so we need both of them to go up. We need both. And so if the female, in a male, they go up like this. If a female has higher estrogen levels naturally, and that's going to vary from female to female, or if she's on birth control or on estrogen replacement, like postmenopausal, then the IGF-1 gets blunted. So then if we need both of them to get the full net effects of growth hormone replacement, then we hypothesize that it may be lower impact in females. Does that make sense? That's the reason for the hypothesis. Now, we may be totally wrong about that. Yeah, most of the time with concussions that do have growth hormone deficiency, 99% of the time the imaging is completely normal. So the imaging has zero value in the diagnosis. Okay. It's actually a biochemical diagnosis, and it's done through something called dynamic endocrine testing, We sometimes call that stimulation testing or provocative testing. And I didn't cover that today, but that's done at an endocrine specialty center. And you go in and the tests, depending on the test that you're doing, it takes anywhere from, you know, two to 4 hours with repeat blood draws after using a pharmaceutical agent that will stimulate your growth hormone and challenge it. And the way I explain it to my patients is it's kind of like I ask them if they've ever made margaritas, and almost everybody says yes, I've almost made margaritas. And so you buy limes on a Monday, right? And you put them like in a bowl, bunch of limes, and then you're going to make a margarita on Friday, and you look at the limes from across the room, and some of them are a little brown, and you already know when you pick those up, if you squeeze them, there's juice, not much juice is going to come out. So that's kind of like abnormal neuroimaging, right? It's like, whoa, okay. So you throw those out, but are there other limes that look exactly like the green limes? They're completely identical, but then when you pick them up and you cut them, they're hard and almost nothing comes out. Have you had that experience making margaritas? That's like the pituitary. So when when you've had a concussion, so you've got to squeeze the lime. You don't know whether juice is going to come out. And that's what the dynamic endocrine testing is. You've got to give a pharmaceutical challenge to can I make a margarita with this lime? No, I can't. Okay, then I'm going to have to replace it with synthetic lime juice, recombinant lime juice, growth hormone, right? And that's probably the easiest analogy that I can use to talk about how we do endocrine testing. But the normal neuroimaging is just like looking at those limes. They're just absolutely, with concussion, most of the time, it's just completely the same as a regular brain. So you got to do the biochemical testing to find the diagnosis. So we can jump into discussion now. Yes, yes. So absolutely. So acromegaly is a condition of excess growth hormone, oftentimes secondary to a tumor, essentially. So you'll get excess secretion of growth hormone from the acromegaly, essentially. Yeah. So when the tumor is resected through the procedures that we showed, either transsphenoidal or craniotomy, then basically they develop growth hormone deficiency. So it's really a post-surgical acquisition, most likely. Does that make sense? Yeah, I agree with that. I agree. Yeah, and that's going to confound and um, complicate the results as well. Okay, and then anything else? Yeah, so part of it, absolutely. So part of it is raising awareness within the endocrinology community and allied health disciplines about growth hormone deficiency. And quality of life is one of the most common outcome measures that are used. And to date, we haven't had a high quality systematic review. The other thing we're going to be doing is using a single, as you know, from Thorgood's work. Is it Thorgood? Blanking on the lead author, and Josh can talk more about that. But we're able to harmonize the constructs across. So we're applying a new instrument to harmonize quality of life measures, and that's never been done. And so we're going to be able to really understand more. This will be the most contemporary paper with the highest quality study on quality of life outcomes after growth hormone replacement. And so part of it is just to make sure that in addition to the other sequelae of growth hormone deficiency, that quality of life is addressed at the highest level, 2024, 2025, whenever we finish the paper. It's well known, quality of life this is a very important topic within the conventional endocrinology community, and it'll be a big contribution. It'll translate into clinical. So most providers that are prescribing growth hormone are using some type of quality of life instrument clinically. The most common one being the QOL AGHDA, the one quality of life assessment of growth hormone deficiency of the adult. That's the most common one that's used in a clinical setting. All of our patients that are on growth hormone do that questionnaire at baseline and then at follow-up, and then as we increase dose. So it can also, titration is important with growth hormone. Not everybody responds to the same dose. And there's debate over whether, at what point, how much do you titrate? How high do you go? How do you optimize? I personally, and some of my mentors, optimize to the highest quartile of the reference range. So with IGF-1. So IGF-1 is used as a screening marker to titrate the growth hormone up, along with the symptom response, to show that there have been changes and benefits from growth hormone therapy. Now, when you're prescribing growth hormone therapy, we often start with a DEXA scan at baseline, as well as with a lipid panel. And so when you're doing prior authorization for growth hormone, it's an expensive medication. So it runs $18,000 to $30,000 a year estimate as of 2019 AAC guidelines. So you can imagine insurance companies don't necessarily want to pay that. And so there's always, there's very strict criteria on who can get growth hormone, and then reapproving the prior authorization. So we have to get a reapproval every year. And this is very important, Melinda, because I'll explain why. And so right now, the outcome measures that are frequently used are, has there been an improvement in IGF-1? Has there been an improvement in cholesterol? Has there been an improvement in bone mineral density? And if there has not been, then they won't reapprove it. And do you think quality of life encapsulates human experience better than any other measure? Yeah. Everything else is very, very mechanistic and medical. And so what if the IGF-1 doesn't go up very much because they're on estrogen replacement? What if they have panhypopituitarism? So it's harder to get that IGF-1 to go up. So there may be a blunted IGF-1 response. What if they didn't have low mineral bone density? Because it takes a long time to lose bone when you have growth hormone deficiency. So what if we caught them a year after a concussion, and now they're on growth hormone? Did they have time to really lose bone mineral density? Or what if their bone mineral density reserve was really, really high? What if they were a guy that was an athlete and had been weightlifting since they were 7, and they had incredible bone mineral density, and we don't even know what it was before, but now it's just normal? And so we don't expect a big improvement, and it takes a while for bone mineral density to improve, 1 to 2 years. So we may not get much of an effect size. So now we can't tell the insurance company, oh, your bone mineral density improved. And what if they didn't have dyslipidemia? Or what if they're on a statin? And now they already had, their cholesterol was mitigated already. And so our 3 outcome measures that are commonly used with insurance companies are not there, and now they can't get reapproval, or there's a fight over it, or it wastes doctors' time writing it. There's a lot of administrative work. One of my mentors had a full-time staffer just for growth hormone prior authorizations, because he had at least 200 patients on growth hormone. So that was her job, full-time, all year long, prior authorization. So my hope would be that quality of life assessment would be used as an outcome measure for insurance companies. And we've got enough of it. We've got a really high caliber group that if we're able to show this human side of growth hormone deficiency, so that if those other outcome measures don't pan out, we can simply say the quality of life improved. So that would be nice. That may or may not happen. But and if it doesn't happen, at least it still helps to clinicians track improvement with their patients, and to be able to, if they're not getting a quality of life improvement, that's not good. And so the dose may need to go up. We need to titrate more. Yeah, and we should be able to present it at the Endocrine Society. I mean, it'll be a high caliber paper, and so we should be able to present this at some point to a large group. Endocrine Society usually has about 8,000, either combined in person and now distance, and so it has a huge impact on endocrinological practice, not just in the United States, but internationally as well. It's an international consortium or group. Right, and they could be, and it could be that you have growth hormone deficiency and you give growth hormone and the person's still depressed, because there's other reasons for depression, right? Part of it is empirical, in the sense that if you have depression and you treat it with growth hormone and it improves, then you have to assume that growth hormone had a contributing factor to the depression. Does that make sense? So that's kind of, you don't know until you treat. You do get undiagnosed concussions as well. that are, in fact, there's really interesting data on emergency department diagnosis of concussion, and there's a huge fail rate. And so they've looked at concussions post hoc that meet the CDC criteria, and about one of the early studies, 56% of concussions are missed in the ER. So you're more likely not to get a diagnosis. And that's been replicated at about similar rates. So you got about a 1 in 2 chance if you've had a concussion when you go to the ER of actually getting a diagnosis. And then there's cultural things around it, especially in sports. So you just kind of buckle up. And, I remember playing football and, seeing stars. It was like, and then the coach says, get your butt back out there. I mean, that was the culture. I had one patient that's got, and I think it was probably from soccer headers, but he said his coach would make him do headers and headers and headers. And he had times where he was, I feel like I'm going to throw up. And the coach just made me keep doing headers, And that's an older culture and that culture needs, but my hypothesis is maybe the soccer headers, because he hadn't had other insults to his brain, but he had really bad growth hormone deficiency. So I'm going to, so this is a fixed dose glucagon stimulation test. So this is the one that we do at my clinic. There's a couple other ones that are done as well. So this is what we do is we inject a hormone called glucagon, which is produced from the pancreas, and that glucagon stimulates the pituitary to begin secreting growth hormone. So it's a challenge test. And so the reason we have to do that is because growth hormone is secreted in little pulses throughout the day, and it goes up and down. And it's got a very short half-life, which means it breaks down quickly. So you can't just run a lab test for growth hormone. If you see somebody doing that and saying you have low growth hormone or high growth hormone, it's not valid, because you could be catching them at a peak or a trough. So you've got to challenge the pituitary, and you got to do repeat blood draws. So what we're doing here is we're taking a growth hormone measurement at baseline, then we're injecting the glucagon, and then every 30 minutes we're taking a growth hormone sample. And we're looking for the peak response for growth hormone. Okay. So a normal, and that can depend on the body mass index for this particular test, but for this individual, a normal response, he should have, to match normal healthy populations and pass the test, he should be above 3. And so he's very, very low. So he's got a very suppressed, severe growth hormone deficiency in this case. So that's how we do it with the glucagon stimulation test. This is a blood draw. These are serum samples of growth hormone. So normally we start around 8 o'clock or 8:30 in the morning. A person comes in fasting. We put them into a room and where they're going to be relaxed for 4 hours. They can do whatever they want for 4 hours, read a book or whatever. And then we take a baseline growth hormone. We inject the glucagon, and then we take growth hormone measurements. You can also look at the cortisol adrenal axis with this, and so we also take cortisol measurements as well. The cortisol also should go up, and it can be a secondary test for adrenal insufficiency as well. But basically, a normal growth hormone response would go very, very high, above 3 at least. I shouldn't say very, very high, but normal ranges for this body mass index should be above 3. But yeah, that's why I said it's really a specialty thing. It's like you can see how hard the diagnostic process is, because you've got to get to primary care or somebody that recognizes it. And then they've got to then refer to endocrinology, and then you got to make sure you're referring to somebody that actually really does a lot of growth hormone deficiency, because general endocrinologists do a lot of different things, and they're kind of like primary care. They know a lot about different conditions. They do a lot of diabetes, a lot of hypothyroidism and thyroid conditions, but they may or may not do a lot of growth hormone deficiency. So sometimes it gets overlooked even in general endocrinology practices. And so, I always say, this is obviously my area of research, but, ideally you go to a neuroendocrinology specialty center. OHSU has one, Barrow Pituitary Center, where Dr. Yuen, who's on our paper, is the head of the pituitary center there. UW has a pituitary center. They've missed cases. They've missed cases of post-traumatic growth hormone deficiency because they didn't run the diagnostic testing, which is an algorithm problem. And it has to do with the screening test for IGF-1. And we're publishing on this too very soon. But the assays that you use to measure it are very different. And so depending on the assay that you use, if you really strictly follow the medical algorithm, you might not test them because of the assay that you're using, because it doesn't meet the algorithm criteria. And then they never run the diagnostic test. So generally, if we suspect it at my clinic, regardless of that IGF-1 level, we're going to go ahead and test. But we also do research on IGF-1, and we know which IGF-1 to use that's going to have a better screening test yield, meaning we're more likely to test them so that we don't miss the diagnosis of growth hormone. Wonderful. Well, it's been great getting to know everybody today, and wonderful. Well, Happy New Year. You'll hopefully, if you develop a relationship with a local endocrinologist that actually really does rigorous work around this, you'll have somebody to refer to for the rest of your career, and you'll help a lot of people. So that's why I love doing these lectures, because it's a community thing, right? We're building a community of knowledge, and that knowledge is power, and it helps people and changes lives. So